gentleman. Now recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you for holding today's hearing. I believe the reforms included in the Affordable Care Act have improved Medicare's long-term fiscal situation and protected beneficiaries' access to guaranteed benefits. And just last week, the Centers for Medicare and Medicaid Services reported that health costs grew just at 3.6% in 2013, which is the smallest increase since 1960. And the reforms included in the ACA have resulted in the Medicare Trust Fund remaining solvent through 2030, which is 13 years longer than the projected date prior to the passage of the ACA. With regard to protecting beneficiaries, HHS announced last week that from 2010 to 2013, there were 1.3 million fewer hospital-acquired conditions, resulting in 50,000 lives saved and $12 billion in health care costs avoided. The ACA pushed health care providers to improve patient safety by providing Medicare payment incentives to improve the quality of care provided and launching the HHS Partnership for Patients initiative. Medicaid is a lifeline for many of my constituents. I'm pleased so many states, including my home state of New York, have taken this opportunity to expand their Medicaid programs and care for the most vulnerable citizens. However, certain governors have used the excuse of the uncertain federal funding for Medicaid as a reason not to expand their programs. I think that's wrong and short-sighted. Looking only at the dollar figures and associated health care spending with regard to the ACA, Medicare, and Medicaid fails to adequately convey the tremendous importance these programs have to the basic well-being and health of millions of vulnerable Americans, young and old. Their value in this respect cannot be understated and should be our primary focus as we look at the long-term fiscal situations surrounding these programs. Let me ask you,
Mr. Miller.
Dr. Miller, by 20, well, let me say this, MedPAC made GMA recommendations a few years ago that many people have used to push for Medicare GMA, graduate medical education cuts. With 1 in 6 physicians trained in my home state of New York, I have concerns that cutting Medicare support for GME or physician training would make it very difficult for teaching hospitals and medical schools to carry out their missions. Additionally, these proposals would change the long-established shared investment between medical schools, residency training programs, and the federal government to financially support doctor training. So let me ask you this. By 2025, the nation will face a shortage of more than 130,000 physicians split evenly between primary and specialty care. Medical schools from across the country have done their part to address the shortage by increasing enrollment sizes, and teaching hospitals are training residents above their cap. Medicare GME cuts could financially exhaust the ability of teaching hospitals to train additional resident physicians. With this said, does MedPAC support the notion of cutting Medicare GME funding?
What MedPAC said, MedPAC in 2010, I think, made a broad recommendation to reform GME, the GME approach in Medicare, and it has the following characteristics. So the analysis that we did suggested that the curriculums that were occurring in residency programs were not really focused on team-based care, decision support instruments, that type of thing, getting training outside of the hospital, getting training in rural areas, that type of thing. So we made a recommendation that there needed to be new criteria to have reorganized residency programs, and then we took a little more than half of the indirect medical education funding and said these dollars should be devoted to entities, and it wouldn't just be hospitals, who are providing this more reformed approach to graduate medical education. So to try and answer your question directly, we didn't take the dollars out of the system, but we said that the dollars should be allocated differently than they are now. A hospital can be a recipient of it if they are part of these reformed programs, but they are not necessarily the only entity for which these dollars would be available.
Okay, let me quickly switch, and just let me give you a general question. Can you elaborate on what you believe are the most promising efforts underway to encourage providers to deliver high-quality, high-value care? Because in your written testimony, you stated that the Commission remains focused on pursuing reforms that control spending and create incentives for beneficiaries to seek and providers to deliver high-value health care services. So what do you believe are the most promising efforts underway to encourage providers to deliver this kind of high-quality, high-value care?
Well, I mean, it's kind of the whole array of things that I mentioned here. So, you know, there are things in the fee-for-service world like readmission penalties and reformulating the way we pay for skilled nursing facility and home health services. We've made recommendations on accountable care organizations to make them more viable options. We've made recommendations, and Congress has adopted the way we have make payments in managed care, and we think that that industry is moving in a much more efficient direction. There's a very long list here with time out here that, but it's in the testimony. The testimony is basically from first to last page, a list to answer your question.
All right, thank you. Thank you, Mr. Chairman.